It's a classic, just deeply frustrating medical paradox.
Oh, absolutely.
Like, you go to the doctor because you're experiencing this really uncomfortable, agonizing burning sensation.
Yeah, right.
And the doctor nods, writes you a prescription for a topical cream to, cure that burning, and you go home relieved.
Yeah, you think it's finally over.
Exactly. But then you apply the medication, and instantly, the burning gets significantly worse.
It is the absolute definition of a counterintuitive treatment. I mean, from the patient's perspective, it literally feels like you're actively harming yourself.
Right. It leaves you sitting there wondering if, your doctor made a massive mistake, or if you're having a terrible allergic reaction, or if this is just somehow how healing is supposed to feel.
It's a terrifying moment for a lot of people.
It really is. Oh, welcome to another deep dive. Today, we're on a very specific mission for you. We're answering a highly specific, totally counterintuitive medical question that plagues so many women.
Yeah, and it's one that doesn't get talked about nearly enough.
No, it doesn't. So the question is, why might a patient experience transient local burning during the first 2 weeks of starting topical estrogen cream?
It's such a brilliant question because, it sits right at the intersection of microscopic human biology and, well, pharmaceutical chemistry.
Right.
There is just a lot going on beneath the surface that isn't immediately obvious when you open that tube of cream.
And to get you the absolute best answer, we pulled together a massive stack of sources for this deep dive. We looked at official FDA prescribing information for products like Premarin and Astras.
Which is very revealing, by the way.
Oh, totally. And we dove into clinical pathophysiology reviews of a condition known as genitourinary syndrome of menopause, or GSM.
The clinical side is crucial.
Yeah, but crucially, we also brought in real-world patient accounts from forums like Reddit and drugs.com because, the clinical data really only tells half the story.
Exactly. The lived experience tells the rest.
Okay, let's unpack this. To really understand why the cream burns, we actually have to take a step back. We can't just look at the medication, right?
No, not at all.
We have to look at the incredibly fragile state of the tissue before the cream even touches it.
That's really where the whole story begins. You can't understand the reaction to the medication without first understanding the environment it's entering.
Makes sense.
So we're talking about the pathophysiology of genitourinary syndrome of menopause, which doctors abbreviate to GSM.
GFM.
And to grasp what GSM does to the body, you first have to understand what the premenopausal vaginal environment looks like when everything is functioning optimally.
Okay, so the baseline.
Right. When estrogen levels are robust, the hormone acts like a master architect for the entire female urogenital tract.
So it isn't just like floating around in the background doing nothing. It's actively building and maintaining physical structures.
Very much so. Premenopause, estrogen maintains a thick, highly resilient vaginal mucosa. We're talking about a protective barrier consisting of roughly 20 to 30 individual cell layers.
Wow, 20 to 30 layers.
Yeah, think of it like a thick, flexible brick wall. It's elastic, it has a massive network of blood vessels supplying it with nutrients, and it can withstand a lot of friction.
Okay.
But the most crucial part of this architecture is what happens at the very surface. The topmost layers of those cells are absolutely packed with a complex sugar called glycogen.
And I'm assuming that glycogen isn't just sitting there for decoration like it's food, right?
It is a 24/7 buffet for a specific type of good bacteria called lactobacillus.
Okay, I've heard of that, like in probiotics.
Exactly. These commensal bacteria naturally colonize a healthy vagina, and their entire existence revolves around gorging on that glycogen.
Okay.
As they eat and metabolize those complex sugars, they release lactic acid as a byproduct.
Which obviously makes the whole environment quite acidic.
Highly acidic. A healthy premenopausal vaginal pH sits right between 3.5 and 4.5 on the pH scale.
That's pretty low.
It is. And that acidity isn't just a random side effect. It's an incredibly powerful evolutionary defense mechanism.
Like a shield.
Exactly like a chemical shield. It actively inhibits the growth of pathogenic bacteria and yeast, essentially protecting the entire lower urinary tract from chronic infections.
Okay, so that's our baseline. We've got a thick 30-layer cellular fortress, a thriving colony of well-fed bacteria, and this highly acidic chemical shield.
Yep, that's the ideal state.
But then menopause happens. The estrogen drops off. I'm looking at the clinical reviews here, and the way they describe the aftermath is pretty stark.
What's fascinating here is the sheer speed and scale of the cascade effect that follows the loss of that hormone.
It's really fast.
It can be, yeah. When estrogen drops, that 20 to 30 cell layer fortress basically collapses inward. The tissue atrophies down to a mere 5 to 10 cell layers.
Wait, if the cell layers are disappearing, then all that glycogen, the food source, has to be disappearing right along with them.
The food source completely vanishes.
Oh, wow.
Yeah, and without the glycogen, the lactobacillus bacteria begin to starve and die off in massive numbers.
Which means no more acid.
Exactly. Without the bacteria eating, the lactic acid production halts entirely. And without that constant drip of lactic acid, the pH of the vagina begins to rise dramatically.
Right.
It often shoots up past 5.0, sometimes reaching 6.5, or even a completely neutral 7.0.
So hold on, a neutral pH of 7.0 sounds incredibly safe. Like usually when we talk about things being pH balanced or neutral, like water or gentle baby soaps, we think of that as a good thing.
Right.
Why is a neutral pH suddenly causing such a disaster down there?
It's a great distinction to make. Neutral is good for your eyeballs or your skin, sure, but the vaginal microbiome relies on harsh acidity to keep invaders out.
Ah, I see.
When the pH neutralizes to 7.0, it's like turning off the electric fence around a property.
Mhm.
Pathogenic bacteria from the gut, like E. coli, which normally couldn't survive the acid bath, suddenly find a highly welcoming neutral environment.
And they just move right in.
They rush in, they colonize, and that leads to a huge spike in chronic recurring urinary tract infections and bacterial vaginosis for menopausal women.
So the chemical shield is completely disabled. But going back to the physical tissue itself, dropping from 30 layers down to 5 layers,
Yeah.
that has to be devastating on a purely structural level.
It is. Along with the thinning of the cells, the underlying connective tissue stops producing collagen and elastin.
Just totally shuts down.
Basically, yeah. The blood flow to the area decreases massively because the body is no longer sending resources to maintain a reproductive environment.
So what are you left with?
What you're left with is an environment that isn't just thin, it's incredibly fragile, bone dry, and prone to microscopic tears and chronic inflammation just from everyday movement.
Just from moving around.
Walking, exercising, sitting down, all of it causes microtrauma.
Reading through these clinical descriptions in our sources, the analogy that immediately came to my mind was severe chapped in winter skin.
Oh, that's a good one.
Like if you've ever been outside in the freezing wind without gloves, your hands get so dry they literally crack open and bleed around the knuckles.
Yeah, it's agonizing.
And when you finally get inside and put even the most expensive, soothing, gentle hand lotion on them, it stings like crazy.
It does.
It's this intense radiating burn. So is that what's happening when a patient applies this estrogen cream? Is the initial burning simply a mechanical issue of rubbing a foreign substance onto microscopic open wounds?
That's a phenomenal way to visualize it. And yes, that mechanical sensitivity is absolutely a major part of the puzzle. You're taking a chemical compound and rubbing it onto atrophic, micro-torn, highly inflamed tissue.
The nerves are just out there.
The nerve endings are practically exposed. It's going to hurt, just mechanically speaking. But that's actually not the only reason it burns. Yeah, there's an active physiological reason the cream burns, and it's directly related to the medicine actually starting to do its job.
I noticed the sources from the Conrad Pearson Clinic talking about this. They use this specific phrase, describing the tissues as having been starving for estrogen for months or even years.
Yes. When you finally reintroduce topical estrogen to these starved tissues, the hormone doesn't just passively sit on the surface.
It goes to work.
It triggers a massive, rapid metabolic reawakening. The local blood vessels, which have been constricted and mostly dormant, are suddenly commanded to dilate.
Okay.
They rush blood flow back into the capillary beds. The local glands, which have been shut down, are suddenly stimulated to start producing secretions again.
Wow.
And that rising pH we talked about, the local fluids suddenly start shifting rapidly back toward acidity.
It sounds like slipping all the circuit breakers in a dark house back on at the exact same time. It's a complete system shock.
A profound system shock. And to the patient's local nervous system, this rapid influx of blood, fluid, and acid shift is incredibly overwhelming.
I can imagine.
The brain interprets all this sudden metabolic activity as burning, itching, or a sudden, terrifying worsening of their original symptoms. But clinically speaking, this chaotic waking up process is the very first necessary step in correcting the underlying atrophy.
It makes me think of when your foot falls asleep because you've been sitting on it wrong for an hour.
Exactly.
Like the blood flow is completely cut off. You don't actually feel pain when it's asleep. It's just numb and heavy. But the second you stand up and the blood rushes back into those starved nerves, You get that agonizing, hot, burning pins and needles sensation.
It's the worst.
It's awful. You have to limp around the room, but you know that the intense pain actually means the tissue is coming back to life. It's surviving.
That captures the sensation perfectly. The burning is quite literally the feeling of rejuvenation.
That's wild.
And the clinical data shows that if a patient can push through this temporary waking up phase and use the cream consistently, those 5 to 10 cell layers will start to rebuild.
How long does that take?
Usually within 2 to 4 weeks of consistent application, the tissue begins to thicken enough that it covers those exposed nerves. It becomes significantly more resistant to the irritation.
Okay, so a few weeks.
Right, and if they keep at it for up to 12 weeks, they can fully rebuild that robust 20 to 30 layer mucosal fortress.
That has to be a huge relief to hear for anyone going through this. Knowing that the burn is just the biological machinery coming back online makes it so much easier to tolerate mentally.
It really does change the perspective.
But this brings up a really critical question for you as a listener trying to navigate this. How can you actually tell the difference? Like, how do you know if you're experiencing this good, temporary healing burn, or if you're experiencing a sign that something is actually terribly wrong with the medication?
It's a vital distinction because as we dive into the patient forums and look at the real-world lived experiences, it becomes incredibly clear that sometimes the burning is absolutely not a natural healing phase.
Right.
Sometimes it's a warning siren.
This is where the deep dive took a really unexpected turn for me. I was reading through these patient accounts on drugs.com and Reddit, and the stories were just wild.
Oh, they're so hard to read.
They were so full of unnecessary suffering. There was one 54-year-old woman who used the cream with no problem for a month and then suddenly developed severe, agonizing burning and itching that wouldn't stop.
Yeah.
She thought she had a raging yeast infection, but all her lab cultures came back totally clear.
Which is an incredibly frustrating diagnostic dead end for the patient. And honestly, it often puzzles their primary care doctors too. They see the symptoms of an infection, but the tests say otherwise.
And then there was this woman on Reddit, and here's where it gets really interesting. She was 85 years old.
Oh, yes, I remember this one.
She started using an estradiol brand cream to help with some local swelling. Initially, it seemed to work fine, but after a few months, she developed what her doctors described as literal bruising all over her labia. She had enlarged, throbbing veins, a fiery, inflamed rash, and a burning sensation so intense she had to apply topical anesthetics just to sit in a chair.
I mean, imagine living with that.
She suffered with this for over a year. 5 different doctors looked at her, and none of them could figure out what was happening.
It's heartbreaking to read, especially because the answer is hidden in plain sight right there on the FDA label of the medication she was using.
Right.
Another account in the sources mentioned a woman who suffered for 3 entire years with horrible swelling and burning before she finally had enough and demanded a vulvar biopsy from a specialist.
Yes. And what did the biopsy show after 3 years of misery?
Yeah.
A severe hypersensitivity reaction, an allergy.
And this is the vital plot twist that you need to be aware of. These patients are almost never allergic to the estrogen itself.
Because it's natural, right?
Exactly. Estrogen is a bioidentical hormone. Your body naturally produces it, even in smaller amounts post-menopause. What they are allergic to are the base ingredients, what pharmacologists call the vehicle of the cream.
The stuff that makes it a spreadable cream rather than just raw, dry estrogen powder.
Precisely. The vehicle is necessary for delivery, but is full of potential irritants. If we pull the official FDA label for estrus, for example, the active ingredient is just 0.1 milligrams of estradiol.
Very small amount.
It's a tiny microscopic amount. But then you look at the long list of inactive ingredients that make up the bulk of the tube.
Oh, boy.
You have propylene glycol, which is a very well-known chemical skin irritant. You have stearyl alcohol. You have harsh chemical preservatives like methylparaben.
Yikes.
And in some generic formulations, the estrogen is actually synthesized using a soy base.
Which completely explains the 85-year-old woman on Reddit.
Yes, exactly.
She noted in her post that she already knew she had a severe systemic dietary allergy to soy. She couldn't eat it. And yet, she was unknowingly putting her known allergen directly onto her most sensitive, thinned-out tissues every single day.
If we connect this to the bigger picture, you have to remember what we discussed back in Section 1. We aren't dealing with normal, healthy skin here.
Right, it's totally broken down.
We are dealing with atrophic, highly permeable, micro-torn tissue. The natural barrier function of the skin is completely compromised.
It's like rubbing alcohol or harsh chemicals on a fresh paper cut versus putting it on the thick, calloused skin of your heel. It's a completely different reaction.
It really is. Ingredients like propylene glycol or methylparaben might not bother the normal thick skin on your arm at all. A lot of everyday face lotions have them.
Yeah, you see parabens everywhere.
But when you apply those same industrial preservatives to the thinned out, bleeding vaginal mucosa, they rapidly absorb straight into the bloodstream and trigger an intense localized contact dermatitis.
Oh.
The immune system sees these chemicals flooding past the broken barrier and launches a massive attack to fight them off.
And that's what feels like an infection.
Exactly. That immune response mimics a severe urinary tract infection. It mimics a yeast infection. It causes rashes, swelling, and severe pain. But it's fundamentally an allergic reaction to the delivery system of the medicine, not an infection.
Which is such a massive, frustrating paradox for the patient. You are taking the medicine specifically to fix the burning.
Right.
The medicine gives you a temporary waking up burn because it's working, but then the chemical base of the medicine gives you a permanent allergic burn that never stops.
It's a cruel cycle.
It's a total minefield. So as a patient standing in your bathroom, how are you supposed to navigate this? If you're experiencing this continuous severe burning that isn't fading after those first 2 to 4 weeks, what are your options?
The good news is that you have several highly effective alternatives, and they all revolve around one simple concept: changing the delivery system to avoid those specific irritants entirely.
Okay, so you don't have to quit entirely.
No, you don't have to give up on estrogen, you just have to give up on the cream.
I saw one incredible success story on drugs.com that highlighted exactly this strategy. A woman who had been suffering from that exact hypersensitivity reaction finally figured out it was the cream base causing her pain.
Yeah, she took matters into her own hands.
She totally took control. She went to her doctor and told him to write a prescription for a compounded estriol cream using a specific hypoallergenic base called Versabase.
A great option.
And she wrote in all caps, "I am cured. I have my vagina back." She entirely bypassed the commercial preservatives by having a compounding pharmacy make a custom, clean version just for her.
Compounding pharmacies are a fantastic resource for exactly this reason. They can strip away all the unnecessary commercial additives.
Right.
But even within the standard commercial medical system at your local pharmacy, there are plenty of FDA-approved alternatives outlined in our clinical literature.
Like what?
Well, if the messy, preservative-heavy creams are causing continuous contact dermatitis, patients can ask their doctor to switch to a vaginal insert or a tablet.
These are products like Vegifem or Imvexim.
Correct. These are tiny, dry tablets or soft shells that you insert vaginally using a small applicator.
Oh, I see.
They contain the therapeutic dose of estrogen, but because they aren't a liquid cream, they completely bypass the need for liquid chemical bases, alcohols, propylene glycol, or heavy liquid preservatives.
You just sidestep the allergy entirely.
Completely. Another highly effective option is a flexible silicone vaginal ring, like S-string.
How does that work?
A healthcare provider, or the patient themselves, inserts the ring high up into the upper vagina, and it simply stays in place for 90 days.
Oh, wow. 90 days.
Yep. It slowly and continuously releases a steady microdose of estrogen directly into the surrounding tissues without any creams, gels, or daily mess to worry about.
Okay, I have to push back on the medical establishment a bit here then.
Fair enough.
If we know these creams are notoriously messy, if we know they frequently cause this intense waking up burn that terrifies patients, and if we know they are packed with chemical irritants like propylene glycol and parabens that cause severe allergic reactions for years, why on earth do doctors prescribe the creams as the absolute first line of defense?
That's a great question.
Why not just start everyone on the clean, dry tablets or the 90-day ring right out of the gate?
It's a totally valid question, and the answer comes down to a messy mix of clinical utility and, frankly, modern healthcare economics.
Economics, of course.
Well, let's look at the clinical side first. From a purely clinical perspective, creams actually are highly effective when a patient needs targeted external application.
Oh, okay.
Tablets and rings treat the internal vaginal canal very well, but they don't reach the outside. Many women with GSM suffer from severe pain right at the vaginal entrance, the vestibule, or they have intense burning right around the urethra.
Ah, I see. And a silicone ring sitting way high up in the vaginal canal isn't going to do anything for the external vulvar tissue.
Exactly. With a cream, a patient can take a tiny pea-sized amount on their finger and rub it exactly where it hurts the most.
That makes sense.
Creams also allow for highly adjustable microdosing. If a full dose is too irritating and causing too much of that waking up burn, a doctor can tell a patient to just use a tiny, tiny dab to let the tissue slowly acclimate over a few winks.
Right.
You can't easily cut a microtablet in half or pause a 90-day reign.
That makes a lot of sense from a physical treatment standpoint. It offers more control. But what about the economic side you mentioned?
Practically speaking, in the United States, generic estradiol cream is significantly older technology and much, much cheaper to produce than the newer patented dissolving soft gels or the high-tech 90-day sustained release rings.
Ah, I see where this is going.
Therefore, health insurance companies are far more likely to cover the cream as a Tier 1 low-cost medication. They will often flat out refuse to pay for the tablets or the ring until the patient can explicitly prove that they failed or had a documented adverse allergic reaction to the cheap cream first.
Ah, step therapy.
Yep, step there.
You literally have to suffer through the allergic reaction to the cheap stuff before the insurance company will let you have the hypoallergenic stuff.
It's the unfortunate reality of the system.
It's incredibly frustrating that the system works that way, but I guess knowledge really is power here. If you know why it's happening, you can advocate for yourself so much faster and skip years of misery.
Absolutely. Understanding the mechanism behind the burn gives the patient the vocabulary they need to talk to their doctor confidently and demand a change in the prescription.
So what does this all mean? Let's put this all together for you. If you are navigating the complexities of menopause and you start a topical estrogen cream and you suddenly experience a spike in local burning, itching, or irritation, don't panic immediately.
Right. It's often part of the process.
It is highly likely that this is just the sudden rush of blood flow, fluids, and acidity changes waking up your starving tissues. It's a biological system shock, but it is a vital healing phase that should pass within 2 to 4 weeks.
However, if that burning feels like a severe, unending urinary tract infection, if you see physical rashes or bruising, or if the pain persists well past a month without fading, you aren't experiencing healing anymore.
Not at all.
You might be reacting to the preservatives, the propylene glycol, or the soy hidden in the cream's base.
And if that is the case, you don't have to just suffer in silence and assume the medication isn't for you. You have the power to go back to your doctor and specifically ask for a different vehicle, like a tablet, a silicone ring, or a compounded hypoallergenic cream.
The estrogen is exactly what you need.
Exactly. You just need a better delivery system that doesn't trigger your immune system.
This raises an important question, though, and it's something the medical literature hasn't fully resolved yet. We established in the very beginning that the ultimate biological goal of estrogen therapy is to restore the glycogen in the tissue so that the good lactobacillus bacteria can thrive and rebuild that acidic shield again, right?
Right. The whole goal is to feed the good bacteria and rebuild the defenses.
But think about the commercial estrogen creams we just analyzed. They are packed with heavy industrial antimicrobial preservatives like methylparaben. The entire purpose of an antimicrobial preservative is to aggressively kill bacteria and mold so the cream can sit on a warm, humid pharmacy shelf or in your bathroom cabinet for 2 years without spoiling.
Wait a minute.
So as a patient, you are diligently applying this cream every night to restore your good vaginal bacteria. But simultaneously, the vehicle delivering that hormone is actively coating your fragile tissues in a chemical explicitly designed to eradicate bacteria.
Oh, wow. That is a huge conflict of interest for your body.
It really is. How much might those exact preservatives be actively fighting against the delicate reestablishment of your vaginal microbiome?
That is definitely something to think about. Until next time, keep diving deep.